Maverick Physical Therapy, body on arm mobility and stability strategies, regimen, intro for the glenohumeral joint capsule, also known as the shoulder joint capsule. In this episode, we're going to refer to this as the sapsule, the hapsule, the thapsule, the scapsule, and the capsule. Because as we talk about the glenohumeral joint capsule, we must also be talking about, at the shoulder joint, we must also talk about the scapulothoracic joint. So scapula, shoulder blade on thoracic spine. We must also be talking about the thapsule, the thoracic spine. We must also be talking about the hapsule, hip joint. We must also be talking about what we call the sapsule, the subtalar joint. A lot to do in terms of implication as to what the rear and the midfoot are doing and the overall functional three-dimensional stability, strength, and mobility that we have throughout the entire chain. In this introduction, we're going to lay out and talk about some very brief principles which are going to drive the strategies and then the techniques that we dig into as I lay out a basic regimen, generally speaking, for the joint capsule, and the integration of meridian-like connective tissue pathways and systems throughout the entire kinetic chain. And then we're going to break things down a little bit more in terms of an isolated integrated faction, using the entire body to troubleshoot various sections of the joint capsule. And so the reason behind that is coming right here in that. Let's take a look at the joint capsule. Capsule meaning ligamentous structure that's holding one bone together at another, which forms a joint. Here we have the humerus, the arm bone, which is sitting on the glenoid, or vice versa, sitting on each other. The head of the humerus is twice the size as the glenoid. Shoulder joint is the most unstable joint within the system, within the human body. The labrum, which is the thin rim of connective tissue that lines the glenoid right here, provides a depth that's about twice as what it normally would be, to provide a little stability, to provide a little more surface area, to provide an area of attachment for the long head of the biceps tendon, on the superior aspect, the inferior aspect, the tricep. So highly concentrated area of tissue throughout this area of the body, meaning the joint capsule and the cuff related type area. With it being a very unstable joint, we run the risk then, like we would at the thoracic spine, the hips, and the feet and the ankles, for things to really kind of get mucked up, to get glued up, and to get gummed up. From a pathological differential diagnosis perspective, in weeding out the root of the problem, cause and effect, the problems that we have, the pain that we have, the injuries that we sustain are a result of other things throughout the system and the body. But there's strategies that we use to take advantage of all these cool little mechanoreceptors that are stuffed within the joint capsule itself, and all of the connective tissue and tendinous-like structures that surround this joint capsule and mesh actually into it. So from the anterior to the front side of the joint capsule, we have what we would call, anatomy-wise of the joint capsule, the inner lining and layer of the joint capsule anatomy-wise is a vascular layer, and that's actually where the synovium is located. So synovial joint fluid that provides hydration to the cartilage-like structures of the adjoining joint surfaces here of the humerus and then the glenoid, and then also to decrease the amount of the viscosity of the fluid, that synovial joint fluid, within that joint right there. So this acts like as a little bit of a piston. So we have the superior, so the top and inferior bottom portion of the joint capsule. We have an anterior front and a posterior back. Anterior wise, we've got a subscapularis tendinous structure, and shifting through that rotator cuff-like structure and system, supraspinatus, superior, infraspinatus, posterior, and kind of lateral, as well as the teres minor, which make up the rotator cuff tendons that actually mesh right into and within that joint capsule. Anterior aspect in terms of other muscular tendinous related structure outside of those inner layers of the joint capsule and the rotator cuffs. We've got the long and the short head of the biceps. We have the pec minor, the pec major. We've got the serratus anterior, the latissimus dorsi, insertion point with the teres major that comes in with a greater or the lesser kind of tubercle right here, and that's all a part of kind of this anterior-like structure. Superiorly, we've got an anterior to lateral to posterior. We've got the deltoid. We've got the traps. As we shift our attention a little bit more posterior, man, a highly concentrated area of tissue between the three tendinous structures that make up the triceps complex with the deltoid, the teres minor. We've got the rhomboid minor and major that are attached medial aspect of the scapula. This is all connective tissue with the lats on the inferior portion of the scap. That with this meridian of tissue all kind of mesh in together. And so it's important that we look at the individual as the individual and not just as some form of shoulder impairment, but we want to look at the mobility of the joint capsule, its surrounding structures. Taking a look at what's at fault is important for making things understandable for the patient and for us, but then also going after, okay, where's the root of the problem coming from? Why do we have X, Y, and Z maybe potentially going on? So the highly concentrated area of tissue, the body is very intelligent, but it's also not very intelligent. With the reproduction and regeneration of some 10,000 new cells a day within the human body, and these collagen-like structures in the form of here fibroblasts, which are cells that create new collagen for the structure of the joint capsule, as well as these tendinous structures, we need to look at what compensation could actually be occurring that's stimulated and triggering the joint capsule as well as these other structures around it to potentially lay down immature, disorganized collagen-like structures and protein, which are adding on to and creating a problematic situation in terms of where we are. And again, refer back to the statement and the comment made earlier, and that we really need to be concerned in terms of the root of the problem and where this is coming from. Inflammation and the pain, we are quick to clinically and in the medical world today to run after and to be this pain chaser and to treat only this, which we need to take a step back and actually go away from that a little bit. So in terms of the shoulder pathology and impairments, we need to take a step back, think about it more globally, more integratedly, not isolated in terms of fashion, because that's typically going to add on to the burden and make things worse. Let's go around and with this this isolated integrated approach to the glenohumeral joint capsule, let's use our body on arm strategies, which is what we use in function anyways in terms of the hips, thoracic spine, scapula on humerus, in terms of our load to our explode strategy, in that we have a body that's moving on an arm. We're not saying that the humerus is not moving. That's definitely not the case, but it's just that the genesis of where motion is rooted and how we move is that we load and we use and take advantage of the ground via the effects of gravity, momentum, inertia, and ground reaction force to load like a rubber band or a slingshot, so that we can start to uncoil and unload in other planes. And it just so happens that in function, we use the upper extremity of the trunk for motions and for functional tasks such as pushing and pulling and reaching in multiple dimensions at a variety of heights, distances, and directions. We also use this system at the end, being this whip-like system. We swing, we throw, and we propel our body and objects that the body uses ultimately efficiency-wise from this kind of proximal acceleration to this distal mobility. So we could think of it as a proximal mobility for distal stability, and kind of vice versa with our body and arm strategy, depending on if we're an open kinetic chain or if we have a hand on a wall, what is or becomes kind of the proximal relative reference point. So through these episodes, we're going to be looking at our body on arm strategies, the integration of the entire body using the scapulothoracic joint, the thoracic spine, the hips, and the rest of the lower extremity to drive and to promote function. These are some very successful strategies that I've used over the years with a variety of patients to treat a variety of needs at a very particular state and time throughout, let's say, a rehab process, and in and amongst as we progress down the way into our performance enhancement like processes, or even better yet, when we're able to prehabilitate. So be able to jump into this stuff without pathology present is obviously the ideal. So on this journey, we're going to be taking a little bit more of an elaborate and in-depth look anatomy-wise. One of our first episodes is going to be a general joint capsule, isolated, integrated approach to going after the shoulder joint capsules in preparation for function and movement, and creating success, something that we can use on a daily basis. And then in our sequential kind of video series, we're going to, in an isolated, integrated fashion, kind of look in on some of these structures and jumping into our stability and mobility matrices, using our upper and lower extremity as drivers in different planes of motion to help stimulate all these cool little sensory receptors that would act to override and bypass our pain receptors. And through the process of just getting really mucky and gunky and gummed up, glued up joint capsules and connective tissue in those surrounding areas as a way to kind of use motion to kind of lubricate, to pry things open, to get those glycosaminoglycans, so the carbohydrate-like structures that with protoglycans protein that form these scaffolding-like structures that allow our collagen to be laid down and to rejuvenate and rebuild a lot of these structures within the system. So a way to kind of get the pump going to within the kind of that inner vascular lining and layer within that joint capsule where the synovial joint fluid is hosted, to kind of get that going so that we can promote good, healthy synovial joint fluid with a viscosity that is very minimal, so that we can keep things hydrated, functioning well, so that we can, throughout our lifespan, so that we can, through and for whatever our occupational, recreational responsibilities are, so that we can just enjoy what we do by being able to manage our own health and wellness with these cool little strategies. So hapsule, sapsule, thapsule, scapsule, and capsule coming up.